Kanski lecture series, and this is chapter 15, Hereditary Fundus Dystrophies part 3. And in this part we are going to discuss about the atypical retinitis pigmentosa. So atypical retinitis pigmentosa include that there are the RP changes, retinitis pigmentosa type changes in the fundus, and that is associated with usually some kind of syndrome. So this is known as atypical retinitis pigmentosa. Introduction. The term atypical RP has conventionally been used to group together heterogeneous disorder clinically having a features in common with the typical pigmentary retinal dystrophy. The precise condition including within this category vary between the authors. So atypical RP that is associated with some kind of systemic disorder syndromic RP. Usher syndrome. So Usher syndrome is usually an autosomal recessive disorders which is genetically heterogeneous, account for about 5% of the cases of all the profound deafness in children, about half of the cases of combined deafness and blindness. So Usher syndrome has a major feature of the systemic is that it consists of there is a deafness in the children. There are three major types ranging from type 1 myo A7 associated 75% which features profound congenital sensorineural deafness and severe RPE with an extinguished ERG in the first decade, to type 3 2% with progressive hearing loss, vestibular dysfunction and relatively late onset pigmentary retinopathy. So there is a type 1 which is most common, which is about 75% associated with myo A7 gene, and it consists of a profound visual loss with severe RPE. And type 3 is basically there is a progressive hearing loss, and there is a relatively late onset pigmentary retinopathy. Systemic features are widely variable and can include premature aging, skeletal anomalies, mental handicap and early demise. So there can be premature aging, skeleton can be anomalies, mental handicap, early demise. There is often a salt and pepper pattern of a retinal pigmentation and optic atrophy. So there can be salt and pepper pigmentary retinopathy, and can be optic atrophy. A study assessing the benefit of inserting the myo A7 associated gene is being undertaken in individuals with this genetic defect. Then there is a Kearns-Sayre syndrome, which is very important. The major feature of the Kearns-Sayre syndrome is that it is a mitochondrial inheritance. It have like CPEO. It has a salt and pepper pigmentary retinopathy, and it is basically the muscle dystrophy, myopathy. It is characterized by the chronic progressive external ophthalmoplegia with ptosis associated with other systemic problems described in chapter 19. The fundus usually has a salt and pepper appearance, most striking at the macula. The less frequent findings are the typical RP or choroidal atrophy similar to choroidemia. Then Behçet-Koens-Weeks syndrome. The most common of this condition is that there is an ichthyosis. Just remember this. Behçet-Koens-Weeks syndrome or A beta lipoproteinemia, autosomal recessive, is a condition in which fat and fat soluble vitamin A, D, E, K absorption is dysfunctional. There is a failure to thrive in infancy with development of the severe spinocerebellar ataxia. So there will be the failure to thrive in infancy, and there will be going to be the spinocerebellar ataxia. A blood film shows thorny red cells, acanthocytosis. The fundus exhibits scattered white dot followed by RP-like changes developing towards the end of the first decade. So there are going to be the acanthocytosis in the red blood cells. Other features include ptosis, ophthalmoplegia, strabismus and nystagmus. Vitamin supplementation and low-fat diet should be implemented. So let's see figure 15.11 is showing a selected systemic association of a retinitis pigmentosa. So A is showing us a ptosis in a Kearns-Sayre syndrome. B is showing as an acanthocytosis in Behçet-Koens-Weeks syndrome, and C is showing ichthyosis in adult Refsum disease. So acanthocytosis is associated with Behçet-Koens-Weeks syndrome, and ichthyosis is associated with Refsum disease. And there is a polydactyly in a Bardet-Biedl syndrome. So Refsum disease, autosomal recessive, consists of a genetically and clinically distinct infantile and adult form. Phytanic acid accumulates throughout the body with substantial and varied skin, neurological and visceral changes. Retinal changes may be similar to RP or take on the salt and pepper appearance, and there may be other ocular features such as cataract and optic atrophy. A low phytanic acid diet can retard progression. Bardet-Biedl syndrome, genetically heterogeneous, can encompass a range of systemic abnormality including polydactyly and mental handicap. So Bardet-Biedl syndrome include polydactyly and mental handicap. There is typically a bullseye maculopathy due to cone rod dystrophy and less frequently typical RPE, retinitis pigmentosa, sign pigmento, and retinitis punctata albicans. Almost 80% have a severe changes by the age of 20 years. So there can be, with the Bardet-Biedl syndrome, there is usually bull's eye maculopathy. Then there is a retinitis pigmentosa sign pigmento, which is basically atypical RPE. Retinitis pigmentosa sign pigmento, RP sign pigmento, is characterized by an absence of paucity of pigment accumulation, which may subsequently appear with time. Functional manifestations are similar to typical RP. So sign pigmento means that almost the function is similar to typical RP, but there is an absence of pigmentation accumulation which appears with the time. So let's see figure 15.12a is showing us a atypical retinitis pigmentosa, a sign pigmento. So you can see that there is an absence of an pigment. Then there is a retinitis punctata albicans, which is a autosomal recessive or dominant, is characterized by the scattered whitish yellow spot, most numerous at the equator, usually spanning the macula and associated with arteriolar attenuation. So whitish yellow spots are most numerous at the equator, and it is usually spanning the macula. They are similar to the spots in the fundus albipectans, and there is a speculation and some genetic supporting evidence that the two clinical presentations are variant of the same disorder. So fundus albipectus is basically sometimes it is associated with that, which is basically a congenital stationary night blindness type. The relative natural history of the two is yet to be completely defined. Nyctalopia and progressive field loss occur in contrast to the benign prognosis believed to pertain in fundus albipectus, and the retinal findings may come to resemble those of a retinitis pigmentosa. So, night blindness and the progressive field loss is the feature of the retinitis albicans puncta albicans. So this is a B is showing us a yellow white spot in the mid periphery of the retina. Then there is a sectoral retinitis pigmentosa. Sectoral RPE autosomal dominant is characterized by the involvement of the inferior quadrant only. Progression is slow, and cases are apparently stationary. Unilateral RP can also occur. So one sector of the is usually involved, and it is usually inferior segment. Then there is a Leber congenital amaurosis. So LCA is also a case of the atypical RPE, which is present in cases of an infant, and it is usually associated with nystagmus, and there is a roving eye movement which is very characteristic of this lesion. And fundus in early cases may appear normal, and then it shows us the changes like a RP. And one of the most important finding is that it is associated with hypermetropia, and it can also lead to keratoconus as well because of the rubbing of the eye. Leber congenital amaurosis, AR, genetically heterogeneous, is a severe rod cone dystrophy that is commonest genetically defined cause of a visual impairment in children. At least 23 genes have been identified, including RPE65 gene. ERG is usually non-recordable even in early cases. Systemic association include mental handicap, deafness, epilepsy, and central nervous system and renal anomalies, skeletal malformation, and endocrine dysfunction. So there can be mental handicap, there can be deafness, there can be epilepsy, there can be renal and CNS anomalies, skeletal malformation, and endocrine dysfunction. Presentation is blindness at birth or early infancy associated with roving eye movement or nystagmus and photoaversion. So usually the blindness will be at birth, there will be roving eye movements and nystagmus. Signs are variable and may include absent or diminished pupillary light reflex. The fundi may appear normal in early life apart from mild arteriolar narrowing. Initially, mid-peripheral pigmentary retinopathy, salt and pepper changes, and less frequently yellow flecks. Severe macular pigmentation or coloboma-like atrophy can occur. So, there are going to be the macular pigmentation and coloboma-like atrophy. Pigmentary retinopathy, optic atrophy, and severe arterial narrowing in early childhood. Ocular digital syndrome, which is basically the constant rubbing of the eyes, may cause orbital fat atrophy with anophthalmos and subsequent keratoconus or keratoglobus. So there will be the rubbing of eye movement which can cause orbital fat, anophthalmos. Other association includes strabismus, hypermetropia, and cataract. Treatment should generally be as of RP, a single subretinal injection of adeno-associated virus-mediated RPE65 genes have shown remarkable result in selected cases. Age of the patient and retinal integrity are the strong predictor of the outcome. So basically, treatment is usually the gene therapy, which is showing us a good results where we inject the adenovirus associated RPE65 gene. So this is a level congenital amaurosis. A is showing mild pigmentary retinopathy. B is showing us a macular pigmentation and optic disc-drusions. C is showing coloboma like macular atrophy, and D is showing us an ocular digital syndrome. So this is a pigmented paravenous chorioretinal atrophy. Pigmented paravenous chorioretinal atrophy, predominantly autosomal dominant, is usually associated asymptomatic and non-progressive. So PPCA, which is a pigmented paravenous chorioretinal atrophy, is asymptomatic and non-progressive. ERG is normal. There is a paravenous. Around the venous, there are bony specule pigmentation is seen together with a sharply outlined zone of chorioretinal atrophy that follows the course of the major retinal vein. Changes may also encircle the optic disc. The optic disc and the vascular caliber are usually normal. So this is a pigmented paravenous retinochoroidal atrophy. So you can see around the vein there is a pigmentation and there is a chorioretinal atrophy associated with it. And these changes are also encircling the optic disc. Then there is a cone dystrophy. Cone dystrophy is basically when the cone's photoreceptor are affected first in the dystrophy. Introduction: the cone dystrophy refers to a wide range of inherited conditions that are characterized mainly by the dysfunction in the cone system. Most cases are cone rod dystrophies, with cones being affected earlier and more severely than rods. So first the cones are being affected and then the rods are being affected. The majority are sporadic with some autosomal dominant and X-linked recessive inheritance. A number of genes have been implicated. As with other retinal dystrophy, the age of onset, severity, and rate of progression can vary substantially. Presentation is in early child adulthood with impairment of central vision rather than nyctalopia, which tends to occur in rod cone dystrophy. The prognosis is usually poor with eventual visual acuity of the 6/60 or worse. So there are going to be the changes which is associated with cones functions, like central vision are first affected. They're going to be the color vision that is going to be affected. Then there is going to be the day vision that is being affected, and the prognosis is usually poor with this disease. Diagnosis: symptoms: gradual bilateral impairment of the central and color vision, which may followed by the photophobia. So there will be the impairment of central and color vision, and there are going to be the photophobia. Signs of feature may evolve through stages below. The macula may be virtually normal and show non-specific central retinal pigmentary changes or atrophy. So macula can be normal and there will be the central pigmentary changes, or there can be atrophy as well. Golden sheen may be seen in X-linked disease. A bullseye maculopathy is classically described but is not universal. So bullseye maculopathy very common. Other causes of bullseye maculopathy variants are given in table 15.1. Progressive RP atrophy at the macula with eventual geographic atrophy. So RP atrophy with eventual geographical atrophy. So we can see figure 15.15. So this is a cone dystrophy. A is showing us an early pigmented mottling. B is showing golden sheen in X-linked recessive disease. So there is a golden sheen. C is showing us a bullseye maculopathy. So you can see that there is an area of a central hyperpigmentation, hypopigmentation, then hypopigmentation. D is showing us a central macular atrophy. So this is a macular atrophy. So what do you do investigation in a cases of a cone dystrophy? Color vision, there will be going to be severe neutron triton defect out of proportion to visual acuity in some patients, so color vision will be defective. Fundus autofluorescence is often the key diagnostic test, showing various annular pattern concentric with the fovea. So it will give us a special bullseye maculopathy pattern in FAF. Fluorescent angiography is never needed these days. However, undertaken is typically show around hyperfluorescent window defect with hyperfluorescent center. So there will be window defect which is hyperfluorescent, and the center will be the hyperfluorescent as well. ERG cone responses are subnormal, but rod responses are preserved until late. OCT shows loss of the outer retinal layer in the macula and foveal region. So OCT will show that there will be going to be the loss of outer retinal layer in macula and foveal region. In advanced disease, there is complete atrophy of macula. Genetic testing can be done. Treatment, there is no specific treatment for cone dystrophies, but lutein, zeaxanthin, and omega-3 fatty acid have been prescribed. In some cases, general measures, for example, low vision aid and minimize phototoxicity. As for rod cone dystrophy, should be considered where applicable. So most of the cone dystrophies does not have any kind of treatment. You just give the patient low vision aid, and you can give some multivitamins as well. So let's see figure 15.16. A is showing us an infrared image. B is showing FAF of patient in figure 15.15. It shows that there is a hypofluorescent area and hyperfluorescent surrounding. C is showing us a fluorescent angiogram showing a typical bullseye appearance, and D is showing us a ERG reduced cone responses. So this is a other causes of bullseye maculopathy. So they are divided into two types, in adults and in children. So in adults, the bullseye maculopathy can be caused by chloroquine maculopathy, advanced Stargardt disease, cone and cone rod dystrophy, fenestrated sheen macular dystrophy, benign concentric annular macular dystrophy, clofazimine retinopathy. In children, most of the time it is Bardet-Biedl syndrome, Haller-Warden's-Spatz syndrome, LCA, Leber congenital amaurosis, lipofuscinosis, autosomal dominant cerebral Teller ataxia. So that's it for part 3. See you in the next lecture.